Good afternoon. Welcome everybody to our Faculty of Dentistry, Massa University webinar series. Our webinar today, the title is Aligners, the Science of Clear Orthodontics. This webinar is arranged by Faculty of Dentistry. And as you know, aesthetics plays a very important role in life, which needs to be addressed with almost significant as facial profile forms as integrated part of it. Over the period of time, there has been an constant surge in the demand for improving aesthetic appearance of the individual with minimal intervention in their function day-by-day activities. Technological advancement in the orthodontics had made a clear alliance as a part of the treatment modalities. Invisible alliance overcome the most common primary reason for which the patients defer treatment, which is aesthetic. Other advantages include maintenance of oral hygiene, better social acceptance, and less chances of injury of the soft tissue. In this webinar today, we will discuss the indication, contraindication, mechanotherapy, attachments, interproximal reduction, and retention protocols for clear align therapy. So, please allow me to welcome our speaker today for this webinar, Professor Dr. Sam Paul. Professor Sam Paul is a BDS, MDS, Head of Department of Orthodontic and Dentofacial Orthopedics, Educare Institute of Dental Science, Malappuram, Kerala, India. Dr. Sam Paul completed his BDS from A.B. Shetty Dental College, Mangalore, and MDS from D.Y. Patil Institute of Dental Science, Navi, Mumbai. Dr. Paul was awarded late the Sauvatsalade Patel Gold Medal for securing highest mark in MDS orthodontics. He is also pursuing his PhD from D.Y. Patel University on clear alliance. He is a professor and the head of department in the Educare Institute of Dental Science from 2012 till date. His research interests are clear alliance mechanotherapy, myofunctional appliances for the orthopedic corrections and orthodontics mini implants. He has been a speaker at various dental conferences for the IDA. He is an active member of Indian Orthodontic Society. Please, everyone, welcome with me, Dr. Professor Sam Paul, and we are welcoming you to our faculty, and please enjoy the webinar. All the stage for you, Dr. Paul.
Thank you, sir. Thank you so much for your kind words. Good afternoon, everyone. It's good morning here. Actually, it's almost 10:15 in the morning here, and good afternoon there. And greetings from all of us here in Educare Institute of Dental Sciences, Kerala. And I'm indeed honored to get this opportunity to speak to you all. This is where I'm heading from, and extend my regards to all the faculties of Massa University, Malaysia, especially my dear friend Dr. Santosh Kotin. We were colleagues during our graduation period, and I still cherish the good times we had in our campus, and especially in the boys' hostel. Right, Dr. Santosh, thank you so much for arranging this. Today's lecture will be, as Sir in the introduction he mentioned, that we'll talk about clear aligners. You all might have heard about that clear aligners. And in this short period of time, we will try to cover a little bit. I am sure 1 hour is not enough, or maybe 45 minutes is not enough to complete a huge topic of aligner. But still, as I got to know that the main audience majority are the final year students, so I think I'll make it as simple as possible so that you will get an idea about what is clear aligner treatment. And once you start your practice after completing your dental undergraduation, you will have an idea about when a patient comes to your clinic or your practice and ask you about, doctor, whether you do Invisalign or clear aligner treatment, you should be in a better position to guide them whether whether you can do it, which cases to do it. In today's class, we will discuss about the indications, which are the suitable cases you should try, and which cases you should not try, and a little bit of history and the biomechanics of clear aligner treatment. And again, step by step, when a patient comes to your clinic, what all things you are supposed to do to get this treatment done. All those things we will discuss in this around 45 minutes period of time. So I hope you all know that orthodontics has come a long way in recent years with advancements in technology, revolutionizing the field and improving patient experiences. And one of the most notable developments is the clear aligner technology. uh, Among the students, I am sure that many of you might have undergone uh, orthodontic treatment, or maybe your family members or your friends might have undergone orthodontic treatment, and you will be aware about what are the problems they used to find during this period of time, during the period of treatment time. Many of them used to complain about harsh. It will be very painful. That's the first thing. Many of the patients complain: the pain and the discomfort, and maybe some cuts and ulcerations on the lips and the cheeks. I come across many people who are allergic to many metals, or maybe allergic to some elastomeric impressions, all those things. We come across all those people. So then another thing is like damage to enamel. When you complete your fixed orthodontic treatment, when you debond the bracket, you could see some white lesions on the enamel. Sometimes damage to the root of the tooth when some excess pressure is applied onto the teeth or for a longer time. So it could damage the root of the teeth. Then, of course, oral hygiene. That is one major problem many of the patients used to complain, because you know that when you have a braces on your teeth, it's very difficult to brush your teeth and to maintain good oral hygiene. Then sometimes moderate to severe pain when you get your wires tightened every month. And maybe, of course, you all may be very unhappy when the doctor tells you, don't eat this, don't do eat that, don't eat any hard things, all those things. So it is going to affect your normal daily routine. So introduction to clear aligner thus came as respite to the orthodontic patient for their aesthetic superiority, made them more attractive to metal and ceramic bracket. Aesthetics, that is one major concern about the fixed orthodontic treatment. Aesthetic. There are these clear aligners are active, clear plastic trays fitting snugly into your teeth, each worn for somewhere around 2 weeks on an average, and it should be changed subsequently to accomplish the incorporated tooth movements. A little bit about the history. The history of orthodontic date back more than 2000 years, when Hippocrates and Aristotle reflected on different ways to straighten the teeth and address various other dental conditions. It was Dr. Lawrence Andrews in 1970 proposed the building the in and out tip and talk into the appliance. You might have heard about Dr. Andrews in your undergraduate classes, and you might have heard about lingual braces. In 1975, two American orthodontists, one American orthodontist and one Japanese orthodontist, together introduced the lingual braces, which you know it is placed on the lingual side of the teeth. Every time people try to get some innovation to make the orthodontic treatment as aesthetic as possible. That's how the lingual braces came into existence. After that, it came the ceramic brackets. You know, the ceramic bracket, the tooth colored brackets. It is called as sapphire brackets, and it is coming. And you might have heard about self-ligating brackets and non-self-ligating brackets, etc. All those things came into existence. In 1945, Dr. H.D. Kessling first proposed a clear vacuum formed tooth positioning appliance for minor tooth movement. Again, I'm sure that in your final year BDS curriculum, you might have heard about Kessling's setup. He was Dr. H.D. Kessling who first proposed the clear vacuum formed tooth positioner appliance. Another half century went until two graduate students of the Stanford University in 1997 applied three-dimensional computer imaging graphics to the field of orthodontics and created the world's first mass-produced customized clear aligner system. After that, the clear aligners have already evolved, and in the early days of clear aligners, most clinicians understood them to be as a orthodontic appliance that is suitable for just very minor cases, like it could be used only for minor spacings or maybe minor crowding and all those things. That's what the earlier thoughts were. Now let's see what are the benefits of clear aligner treatment. First thing is, as I told you before, is the aesthetic appeal. So the clear aligners are virtually invisible. I will never say that completely invisible, but virtually invisible, making them an attractive choice for those who wish to straighten their teeth without the appearance of the metal braces. And the transparent material ensures that the aligners set seamlessly over the teeth, allowing individuals to undergo orthodontic treatment with confidence. Again, it's removable and it's convenient. One of the main advantage of aligner is that removability. Unlike braces, which are fixed in place throughout the treatment duration, clear aligners can be moved and removed whenever it is necessary. Again, as I told you before, improved oral hygiene. Since they can be removed, individuals can maintain their regular brushing and flossing and all the routine things without any obstructions. Enhanced comfort. These aligners are made according to the individual's teeth alignment so that they can fit easily over the teeth, providing a more comfortable orthodontic experience. And again, predictable results. If you have undergone orthodontic treatment, when you come first to the orthodontist, you ask the doctor, everything will be okay. Will I get a good smile? Of course, we all say, of course, you will get a good smile, but still, that is a predictable result. Like we are trying our best to get a good result for the patient and a good smile to the patient. But in case of aligners are designed using advanced computer technology, allowing the precise, predictable teeth movement. Everything is predicted prior itself. How your teeth are going to be after the treatment, and how you can virtually see how your teeth look after the treatment. You can see it, and if you have any modification, you can inform the orthodontist, see, I want this to be corrected, that to be corrected. You can tell prior to the beginning of the treatment. Through a series of aligners, each slightly slightly adjusted from the previous one, the teeth gradually shift into their desired position. Minimal lifestyle disruption. Unlike braces that require periodic adjustments and potential emergency visits, you might have heard about broken wires and broken brackets, or some wires are poking to the cheeks and all those things. All those things are minimized in case of this aligner treatment. And again, fewer visits to the orthodontist. Nowadays, what we as an orthodontist, what the main problem, what all the patients are complaining, that nobody has time to come for regular monthly visits for the regular orthodontic checkup. That is one major concern, because the patients who undergo orthodontic treatments are majority mainly students. So they have to take leave from their schools or colleges, and if they are kids, they cannot come alone. Their parents also has to take leave every month almost. You know, the orthodontic treatment almost extends up to almost 1 to 1.5 years. So every month to visit an orthodontist for regular checkup for fixed orthodontic treatment is very difficult. So in case of aligner treatment, that problem is also solved. You don't have to visit your orthodontist in a regular basis. You can only, if you have some problem, you can go. Otherwise, you don't need to visit an orthodontist every month. That is the major advantage of aligner treatment. Let me just show a few cases which we have completed using clear aligner treatment. This patient, he was almost 23 years. He complained of spacing in the upper front teeth since last 10 years, and patient was not willing for the conventional orthodontic treatment. And this is his pre-treatment extra oral view. You can see his front view and the lateral view and the oblique view. In this, you can see the malalignment of his front teeth. This is his intraoral view. You can see there is proclined. The patient complains about proclined upper maxillary anterior teeth with spacing in between the teeth. That was his problem. So we completed this case with clear aligner treatment. This is his maxillary view and the mandibular view, occlusal view. And this is his OPG and his lateral cephalogram pre-treatment. And this was diagnosed as Angle's class 1 bimaxillary proclination on class 1 skeletal base and average growth pattern, spaced upper anteriors, deep bite, rotations in relation to 2-4-4-4-3-2, and deviated lower midline with tongue thrusting habit. This was his with the aligners. This is a wear schedule for aligners. I will explain to you in the coming slides what is a wear schedule. In this, you can see the first date. Can you see that? The starting date. It is 9/6/2022. Okay. The ending date. That is almost, I cannot see the slide. 1 second. 7/12/2022. Yes. Okay. So the first tray, the patient had almost 13 trays in altogether. The first tray, the upper and lower tray, was delivered on 9/6/2022. The patient is supposed to wear this first aligner till the ending date. Can you see this? This is 22/6/2022. From 9th to 22nd, this patient is supposed to wear his first stage 1 aligner tray. On 23rd 6 2022, he is supposed to wear his second tray till 6/7/2022. On 7/7/2022, he is supposed to wear his third tray. So As I told before, this is completely pre-planned treatment. Aligner treatment is concerned. You are supposed to wear this particular aligner for this particular date. The teeth movement happens. Whatever teeth movement is supposed to happen in the first tray, second tray, third tray, and all those trays, that will happen in that particular days. So what you need to do is just keep on changing the tray till the last tray, that is the 13th tray. That is the wear schedule. All the aligner patients will be having such a wear schedule. In this, he is supposed to tick whichever tray he is completed, he is supposed to tick it off. Okay, and by when the patient reaches his 13th tray, whatever treatment plan we have or whatever we have planned for this treatment, he might be achieving all those results. Okay, this his pre and post treatment result. Entire space has been closed. Here you can compare. See, patient had proclination here and spacing here. You can appreciate the proclination and spacing is completely reduced. This is occlusal view. You can see the spacing here. The entire spaces are closed here. This is the extraoral view. You can appreciate the changes happen here in this lateral cephalogram. You can see the proclination here. The proclination is almost considerably reduced. And right now the retention phase is going on with the Hawley's appliance. And since he had a tongue thrusting habit, we have given a tongue thrusting appliance also here. The tongue crib you can see here. Okay. This patient named Rima, she had a main complaint about crowding in the upper front teeth since last 5 years. And you can appreciate what changes have happened here. This is the pre and the post. She had severe crowding in the anterior section, buccally placed canines, and you can see the post-treatment result here. This is a pre-treatment intraoral view, and we had to go for extractions. All the first premolars have been extracted, both the upper and lower first premolars, and to that space we used that space to correct this canine to get into the alignment and decrease the crowding. Here you can, this is an occlusal view. Here you can appreciate the good alignment here. And this is the extraoral view. This is another patient, he's just 17 years old. The main complaint of his patient was spacing in the front teeth. This was his main complaint. And this was completely cured with the clear aligner treatment. This is the pre-treatment intraoral view, and this is the post-treatment intraoral view. All the spaces have been closed. This is the occlusal view. You can appreciate the patient has got a well-aligned maxillary and mandibular arch. This is his extraoral view. You can see the difference. Okay. Another patient, Shrishma. She complained again of spacing in the upper front teeth. In this, the midline diastema, I hope you all are familiar with that word, midline diastema. The main cause of the midline diastema was the frenal attachment. So the frenectomy was done prior to the treatment, and then the aligner treatment was carried on, and this is the post-treatment result. Here you can appreciate a well-aligned arch here, with all the spaces are closed. And here you can appreciate the extra overview. Another patient, Farsana, again 23-year-old, and she complains of increased visibility of the upper front teeth for 5 years. You can appreciate the visibility here. Again, patient doesn't want any extraction of her teeth because when we had told her before itself that there is some proclination on the front teeth, but she is not willing for any extraction, so we had to manage it without any extraction. So this is the pre-treatment and the post-treatment result. We won't be able to appreciate much difference here, but patient was not willing for any extraction in this particular case. So we had to complete this case in this particular way. Okay. Again, the visibility is reduced. Okay. This is another case of spacing. This is class 2 correction. You might have heard about class 2 dental pattern. You can see the model relation here. This is a class 2 div 1 malocclusion, and this was corrected with that. There is something known as the latest modification of clear aligner treatment, that is a clear aligner twin block treatment. You might have heard about twin block, which was invented by W.H. Clark for the correction of class 2. And nowadays, we can do twin block correction with aligner treatment also. This is another case of spacing. Okay. Coming to the advantages of, I think I don't want to repeat the same thing. You know that aesthetics, comfort, improved oral hygiene, no food restrictions. That's the main thing. You can eat anything, but you don't eat wearing the appliance. You have to remove the aligner appliance when you're having any food. Of course, everything has got a plus and minus things. Okay, there are some limitation as far as aligners are concerned. So the first thing is the patient compliance. We all know that if we ask the patient to wear any appliance for 22 hours, patient will wear only for 2 hours. But we used to see that. But there is one major limitation. If the patient compliance is most important, the patient doesn't wear that appliance for that particular time, that is going to that is going to hamper the result of that treatment. Then limited extended tooth movements by aligners. For complex movements, you need to have some auxiliaries or maybe elastics attached to it. You need to incorporate elastics or auxiliaries to the aligner. Then the major concern again is a higher cost. It is much more costlier than conventional fixed orthodontic treatment. Breakages, if you are not careful while removing the braces or wearing it, there are chances for that thermoplastic appliance to break. Chances of losing the aligner. Removable nature makes aligners prone to being misplaced. And inconvenience. Some people might complain that removing aligners every time whenever he want to eat or drink, that is another inconvenience. And maybe some manufacturing defect also. So this CAT means clear aligner treatment, works on two basic principles. One is creating space. Another one is force pressure application. You should remember that the basic principle of clear aligner treatment is one is creating space. You need to create space. And another one is force pressure application. To create space, you need to do either expansion, tooth extraction, or proximal reduction. In your undergraduate level, you might have heard about methods of gaining space. In that, the three major things that are expansion, extraction, and proximal stripping. Okay. So I will explain to you in the coming slide what is an IPR or interproximal reduction. That is one major thing you supposed to know how to do a proper interproximal reduction without damaging the enamel. Interproximal reduction is the key for aligner treatment. If you are good at interproximal reduction, you can do any case in clear aligner treatment. Okay, and the biomechanics. The mechanics of tooth movement with clear aligners is centered around two systems. One is displacement driven system and force driven system. What is displacement driven system? There is aligners are fabricated as per next stage position. What movement you need in the next stage of the treatment that's incorporated into the previous aligner. That is, aligners are fabricated as per next stage position. The tooth continues to move till the aligner becomes passive. When you put an aligner, the first aligner, second aligner, whichever aligner it is, you feel it's very active. You can feel that pressure onto the teeth. So when the desired tooth movement is accomplished with that particular aligner tray, you can feel that the aligner becomes passive. Okay, that is the time when I showed you the chart, you can see you might have seen that. That time you need to change to the next tray. The other one is force-driven system. The software determines the type of movement required for individual tooth. The mechanical principle needed to achieve that movement and the aligner shape. Okay, what are the materials what we use? That is mainly polyethylene terephthalate glycol modifier. That is PETG, PETG, PETG. That's the most commonly used material. And right now, the newer materials have come that is known as shape memory aligners. You might have heard about shape memory wires, the nitinol wires, NITI wires. Okay, so the same way, aligners have also come up with a newer modification that is known as shape memory aligners. While the soft layer imparts the property of elastic deformation, allowing smooth seating of the aligner, the hard layer ensures strength and the stability. And the staining of the aligner. Some people used to ask whether these aligners will stain or not, because aesthetics is the main concern when a patient has shifted his treatment plan from fixed orthodontic treatment to aligners. So paying this much, will the aligner tray stains? But yes, of course, it sometimes it stains. Color changes in aligners have been reported on exposure to staining solutions such as coffee, black tea, and red wine. And it is more prone to pigmentation when exposed to coffee and red wine. So it's better, I won't say to avoid coffee, but it's better to remove the appliance before when you're taking black tea or black coffee. So now let me come to a practical aspect. Like when a patient come to you, you might finish your undergraduate courses and you start your private practice or your clinical practice. A patient comes to your clinic asking about whether that patient can go for a aligner treatment or not. So what are the things you are supposed to do? First thing is, as for any orthodontic treatment, the first thing is diagnosis and treatment planning. First, we have to diagnose what the problem is. Again, you might have heard about case history and the chief complaint and everything. You should be mainly concerned with the patient's chief complaint. The previous one case which I showed you, the last case which I showed you, see, there is slight amount of proclination, but the patient is not concerned about that. So we had to go with the chief complaint of the patient. We have to address the chief complaint of the patient. So the first thing is diagnosing and treatment planning. Okay, how to diagnose? What's the diagnosis of this particular case, and what the treatment planning? Then medical and dental history. Of course, you take it for all your dental treatments. Then radiographic and photographic records. That's a must, because radiography means you have to take an OPG, orthopantomogram, and an elastic cephalogram. OPG is a must for I do for all my cases, whichever orthodontic treatment I am doing, even if it's a conventional fixed orthodontic treatment, I make sure I take the radiograph for all the orthodontic patients. Why? Because there I had to face few cases where luckily I got saved. I remember one patient came to me. She's just around 16-year-old. She came with her family to my clinic, and the main concern is that she had some crowding in the front teeth. Also, they require some orthodontic treatment. Just before starting my treatment, I asked them to take an OPG. I was surprised to see the patient was having ameloblastoma. You might have heard about ameloblastoma, right? So, if I had not taken that radiograph before my orthodontic treatment, and if I had started that treatment, you know what's going to happen, right? So, I make it sure that I take radiographic records and photographic records and the impressions for all my orthodontic cases. I think even for a legal safety also, it is mandatory that you are supposed to have all the records taken before you started treatment. The fourth point is the impression, what impressions you are supposed to make. Then this impression, whatever impressions you have taken, you might have heard about alginate impression, PVS impression, the putty light body impression, and again the digital scanning. The digital scanning is the most recent one and the most accurate one. So, any of the, if you are able to take a very good alginate impression, that also serves your purpose. But again, putty light body impression is the most suitable one. And if you have an intraoral scanner, best. Then this impression, whatever you have taken, is sent to the lab. The lab in the lab, what they do, they use the CAD CAM technology, and they do a treatment planning. In the coming slides, I will show you that. And again, you discuss your plan with the orthodontist for sure, because only orthodontist can tell you and guide you to get a proper orthodontic treatment plan. Then you get a plan from the lab. You discuss this particular plan with the patient, where the number of aligner tray and the cost of this treatment. Then, if the patient is okay with it, then the lab will issue a IPR chart, the inner proximal chart. That is the most crucial thing. And you are supposed to do, you have to perform an IPR that I'll explain to you in the coming slides. And then the zero tray. Zero tray means that's the first tray which you give to the patient to see whether the impression is perfect or any changes has to be made or not. And the final thing is delivery of the aligners. Coming to the orthodontic selection, case selection. I'm sure I don't know how many people might have already done clear aligner treatment, but I always recommend all my friends that start from easy cases, go to very basic cases like mild spacing, mild crowding, and all those things, so that you get a hand of it, and only then you can move up to difficult cases like extraction cases, extrusion cases, posterior cross bites, and all those things. You can go. Again, I explained to you the medical and dental history. Again, patient's expectation. The patient's expectation is too much actually. Nowadays, I have some cases where when the patient is asking me, can you give me an Aishwarya Rai smile? You might have heard about Aishwarya Rai. She's a famous film actress in Bollywood. So there were patients asking me whether can you offer me an Aishwarya Rai smile? See, this is not possible. So you should be you should really know how to tackle the patient's expectations. Then the integral step will include analyzing the alignment of the teeth, assessing the relationship between the upper and lower jaws, and evaluating the overall facial profile. Again, I told you the basic records. You are supposed to take an OPG and a lateral cephalogram for all your aligner cases. Photographic records. You are supposed to take extraoral view, smiling view, lateral view, and oblique view, both intraoral and extraoral. Intraoral, you are supposed to take an occlusal view also. This is mandatory for all your aligner treatment. Coming to impression material, I spoke to you about alginate impression material. If you are good enough, some companies won't agree for alginate impression material, but still, if you are really good in mixing an alginate with the correct powder liquid ratio, then you can go for an alginate impression material also, or the previous siloxane impression. You might have heard about putty light body impression and the intraoral scan. The intraoral scan allows the practitioner to visualize patient's dentition in a 3D, which helps in viewing the position of every individual tooth and its relation to the other teeth. So, this was one picture of what intraoral view of a patient. When in the clinic, you take these views and you send it to the lab. What the lab does is they do a digital smile design and the treatment stimulation with the CAD/CAM technology. And this was the view. Let me see whether it's opening or not. Yes. This is a 3D model of the same patient. So when we give all these photographs and the impression to the lab will give you such an animated 3D video. So you can see it perfectly and you can show the patients. You can see the teeth movement of the teeth in this stimulated video. This is a maxillary occlusal view. You can see the expansion happening and the teeth getting into alignment. In the lower jaw, again you see the teeth are getting aligned. Okay. Okay. So I hope you remember that the patient has come to your clinic. You take the initial dental and medical history, the chief complaint, the case history, normal cases you take. Then you take the intraoral and extraoral photographs of the patient. Then you take the radiographic records, that is the OPG and the lateral cephalogram, and you send all these things to the lab. So the lab will give you the animated video which I shown you before, the same type. They will give you an animated video. And next, you show this to the patient and the lab will tell you an approximate cost and the number of aligner tray and the total treatment time, an approximate charges and the treatment time will be informed to you, and you will inform the same to the patient. And if the patient is willing for the treatment and the cost whatever you are quoting, you tell the lab that okay, that we are going ahead with the treatment. The lab will issue an IPR chart. This is an IPR chart, that is interproximal reduction chart. This is the central incisor. This is the first quadrant, the second quadrant, third quadrant, fourth quadrant. You could see this is we have to create some space between the teeth. You can see that 1.5, 1.4. You are supposed to do interproximal reduction between these teeth. And there is an interproximal gauge to measure this point 1.5 to 1.4 or 1.3, whatever it is, you could measure it. And you are supposed to do an interproximal reduction with your most tapering fissure burr, or maybe there are some strips available to do an IPR. You're supposed to do that. That is an IPR chart. You have to perform that. This is a video of how to do an IPR. Let me just, you can just mute that. One sec. In this particular tip, you are supposed to do in the proximal reduction. Here they are using abrasive strips. This is how you do in the proximal reduction. You need some space here between this teeth for the alignment. Can you see that? The abrasive strips are available in the market. You have single-sided and double-sided strips. So, can you see that small amount of space what we achieved in between the teeth? You can use an abrasive disc for reshaping the mesial and the on both the mesial surfaces. Yes, can you see that? Yes. We have around 10 to 15 minutes more, I think. Okay. Another important thing, what you're supposed to do is there is something known as attachments. You have to incorporate attachments. Can you see these blocks here on the labial surface of the teeth? These are known as attachments. These attachments provide additional support for aligners, enabling controlled tooth movements like rotations, extrusions, or intrusions. What we do is we strategically place attachments based on the treatment plan to enhance the predictability and efficacy of the aligner treatment. Okay. About treatment duration, patients should understand the duration of clear aligner therapy. It can vary depending on the complexity of their malocclusion. Some cases it might take only 5 months, 6 months, 8 months, and if it's an extraction case, of course, it could go somewhere around 1 year. By explaining the estimated time upfront, we can manage patient expectations and elevate any concerns or frustrations that may arise. Again, there could be some potential discomfort and speech changes initially. When you put the first aligner tray, many of the patients might complain about slight discomfort and the speech change. So we have to prepare the patients and enhance overall patient compliance by effectively educating the patients about the potential challenges associated with speech adjustments and minor discomfort that may arise during the initial days of of wearing aligners. It's very minor. I mean, when you compare with your fixed orthodontic, conventional orthodontic treatment, the discomfort is very minimal. But still, you have to convince the patient, you have to inform the patient prior that there could be some potential discomfort during the initial time. The overall health, the patient must understand the importance of maintaining excellent oral hygiene practices throughout the treatment. That is a must for any treatment. Practitioners can demonstrate the proper brushing, flossing, and rinsing techniques to prevent plaque buildup and maintain optimal oral health. As I told before, it is crucial to educate patients about their role in treatment process and emphasize the importance of wearing aligners for the recommended duration. When you start your treatment, you will come to know it's very difficult to make the patient wear that appliance almost 20 to 24 hours. I don't, the companies recommend that 22 hours of wearing that appliance. But I personally tell the patient you are not supposed to remove the appliance at all unless and until for only while eating and brushing. If we say that 22 hours, patient make it as to 10 hours or 15 hours according to his wish. So, patients should be made aware of the potential consequences of inconsistent and inadequate aligner wear. If the patient is not wearing that aligner up to that whichever date we have told, at least minimum 22 hours, the desired movement which is supposed to happen with that particular aligner tray will never happen. So the patient, if the patient shift the first tray to the second tray, the second tray won't fit. He has to wear that aligner tray according to the time which is scheduled to him and according to the date which is scheduled to him. These are the attachments which I showed you. Can you see this? Attachments are small ridges made of orthodontic material that are bonded to your teeth. They are completely tooth colored, so they blend in well with your enamel and comes in various shapes and sizes depending on the function. Your aligner will fit perfectly and smoothly over them. These attachments serves as an anchor point that is needed to help to apply the force of the aligner. Different shapes of the aligner. This is ellipsoid. Different shapes of the attachment. You have ellipsoid, rectangular ones, beveled ones. These are extrusion attachments. Anterior extrusion, deep bite attachments, bite ramps. That's for deep bite correction. That which is placed at the cingulum area of the maxillary anteriors for the molar retention. Okay. So how are the attachments applied to the teeth? You all might have seen how you do a proper normal composite bonding. You all might be very familiar with that. First, you have to do the etching. You know, 37% phosphoric acid is used for etching. Then the primer is attached. Then you have a template. You have a template with you. With you have the all the indentation of this attachments on that template. You are supposed to put some flowable composite to that embrasures and just place on the patient's teeth and do the light curing. It's very simple to do an attachment. This is a huge video. Actually, let me try to show you. If you can mute the audio. Yes. This is a template from the lab. They'll give you the maxillary and mandibular template. This is a flowable composite. So you can apply this flowable composite to this embrasures of the attachment. There is an embrasure here. Okay. Apply very small amount of flowable composite here. See, this is the teeth wherever the attachments are supposed to be placed. Now you prepare the patient. As I told before, you have to do the etching and apply the primer, same as you how you do a composite filling. This is 37% phosphoric acid. You etch only on those teeth which are indicated for placing the attachments. After 20 seconds, you wash off the etchant completely from the teeth. Then wash the entire etchant and then blow air to dry the enamel till you get a frosty appearance. You might have heard about white frosty appearance. Then you apply the bonding agent, or we call it as primer, onto those etched enamel surface. Then you load the same aligner tray, which is a template where we have already placed the flowable composite, and you place it onto the patient's teeth, and it should be fitting perfectly onto the teeth, and you do the light curing. Can just remove it. It will be a little bit difficult to remove it once you place the attachments, but still it's okay. You can pull it out. You can use a sickle scaler to just pull it off. There is the attachment. Can you see the attachments here? Okay. Let me just go forward and we'll skip all these slides. Okay. This is one major concern regarding aligner treatment. Once you complete the aligner treatment, you'll be surprised to see there's a posterior open bite. So don't be worried about that. There's a very common complication. That is the open bite is just because of the thickness of the both the maxillary and the mandibular aligner trace. So once you give a retainer, it completely closed by itself. So you don't need to worry about that. Coming to the retention. As for any orthodontic treatment, retention is the major concern for any orthodontic treatment. See, you have uh, relapse, which you cannot avoid at all in orthodontic treatment. So the same applies here also. So you have to follow proper retention protocol. What I give is that I go for fixed lingual retainer for all the patients when I complete the aligner treatment, so that even if the patient is not willing or patient doesn't wear the retainer, still the it won't hamper the inner treatment results at all. This was the proximal stripping which I said. So in the proximal reduction, again, I again come to that last point. In the proximal reduction is the major, most important thing as far as aligner is concerned. If you can do a proper interproximal reduction, your aligner treatment will be a success. It is the removal of a small amount of enamel between the teeth to reduce the width. The aim of the reduction is to create space for ideal tooth alignment during orthodontic treatment and to give teeth a suitable shape whenever problems of shape or size require attention. When you do it for crowding, inter-eye discrepancies, tooth shape and dental aesthetics, sometimes there is macrodontia, the size will be too large. So that time you do, then crowding the mandibular anteriors. We don't go for extraction of this mandibular anterior in this case. We just do in the proximal reduction to create space. To be performed on temporary to improve occlusion and normalization of gingival contour. And do not attempt interproximal reduction when there is severe crowding. You have to go for extractions in those cases. So never go for interproximal reduction when the patient is having severe crowding, when there is very poor oral hygiene and too small teeth. There are some cases when we could see that patient having very small teeth, the crown length will be too short. So that is also contraindication, and some patients are susceptible for decay and severely rotated teeth. You don't go for interproximal reduction. So, how much enamel can be reduced? There are no studies indicate how much of enamel is needed to adequate protection of the tooth against caries or thermal change. The variation in thickness of enamel suggests that there is no protective advantage in preserving thick enamel interproximally when comparative thin enamel occurs naturally on labial, buccal, and lingual surfaces. So many textbooks suggest that 50% of interproximal enamel could be removed. 50%. Okay. This I've shown you that you could use abrasive strips. You could use this saw. The first thing you have to separate the teeth with separators so that you get some space between the teeth, and then you start reducing. You can, if you're very good with your hand, you can use a small interproximal reduction burr also to do the interproximal reduction. Then after you use the burr, you have to use these strips to completely contour the mesial and the proximal surfaces. You have to do polishing and protection. I don't want to go in detail about this. Okay, you have to be very careful not to injure the tongue, lips, and the cheeks. Always you take your finger rest when you do that procedure and check for fully broken contact. The contact has to be completely broken. There are some cases, but when we see the inside cell tip, the contact will be broke. But when you go to the gingival level, the contact won't be fully broken. So that again hampers the movement of the teeth when you use the aligners. This is the gauge which I talked about. You see the measurements are in comes like zero point 0.5, 0.6, 1.2 and all those things. So you need to use this particular gauge to measure that small minute measurements. The main disadvantage, if you don't do an IPR properly, the rough proximal surface, of course, that will attract the plaque. Again, that goes to caries and the decay of the teeth. Patient will complain about sensitivity, can result in alteration of morphology of the teeth, and again, of course, food impaction. So, with this, I conclude that presentation. I think this is time for any questions to be asked. I know this is very short time to complete a huge. We normally take it for a day actually, but in this short period of time, we could use only. Well, I could discuss only this much with you. So, Dr. Santosh, any questions from your side? I'm free to answer.
Okay, thank you, Prof. Dr. Sam, for the wonderful presentation.
Thank you, sir.
Nice to have you today here with us.
Thank you, sir.
For my side, I don't see any questions from the audience.
Oh, yes, yes, I know.
I think your presentation is very wonderful. Everybody is understanding very good.
Thank you, sir.
Yeah. So I would like to thank you again to be
Yes,
with
sir.
us here, as well as Dr. Santosh here behind me. You can see him as well.
Yes, I can see him. Yeah. Thank you, Santosh.
You
Oh, yeah.
here?
Thank you so much for the opportunity, sir.
Thank you very much.
Thank you so much.
Thank you very much. Have a great day and take care.
Thank you, sir. Thanks a lot.
Looking
Thanks a lot.
forward
Santosh,
to meet you
we'll
more.
meet up again.
Sure,
Santosh.
sure.
Bye.
Okay. Thank you.
Yes, sir. Thank you. Bye, bye, bye.
For our audience, we would like to thank you, everyone, for joining us this webinar. And we wish you always have a good day. Take care and bye. Thank you.